Hello, and welcome back to the Bond Air Podcast. I'm Jesse Longo, your host, Associate Director of Nursing here at Bond. We have a fantastic episode lined up today. I'm joined with my co-host, Dr. Jeremy Kimmelsteele, our Regional Director of Operations. How you doing, Jer?
Awesome.
Excited to have you. I've been actually saying I want to say excited less. I feel like the more it's said, the less it means. So I said fantastic earlier. I use elated recently, so I'm trying to get away from using excited all the time. Anyway, I will now introduce our guest, who we are stoked to be having today. We're going to be chatting with Dr. Alex LoPinto, Medical Director of the Veterinary Eye Center. Dr. LoPinto is a graduate of Cornell University and a board-certified veterinary ophthalmologist. After completing his residency at Tufts, he managed a wide range of ophthalmology cases at a busy specialty hospital in New York City before launching his own standalone specialty practice, the Veterinary Eye Center, focused exclusively on ophthalmology. We are going to be chatting today with Dr. LoPinto about an exciting topic. See, I did it. A topic that a lot of our clinicians in our clinics are often thinking about, as I think eyes are kind of scary to our team sometimes. I know they're scary to me for sure, but corneal ulcers. We'll dive deep into that topic and get a better understanding of what current literature is saying and kind of how you're practicing in your clinics, and maybe some advice for our general practitioners of how they can kind of stabilize those cases and ensure that we're setting them up for success. So, Alex, how are you doing today?
I'm doing great. Thank you.
Thanks so much for being on. For our teams, I know you had a talk with our teams at our beer rounds a couple of months ago at this point, and that was like super well received. And you said you did a talk recently that definitely, perked a lot of ears. So I'm wondering for you, what are some of those first ideas when you're thinking about either putting a talk together or like the main focus points of treating corneal ulcers? What kind of sticks out to you in that area?
Yeah, for sure. Well, thanks for having me. Happy to be here. And, corneal ulcers can definitely intimidate people, as most ophthalmology cases can, just because you're limited sometimes with your equipment. You don't know exactly how deep certain things are if you're not able to magnify it well. But the important thing to remember is that the cornea is excellent at healing. It can really do a good job healing. So you just want to provide a good environment for that corneal ulcer to heal. And so, when putting together a presentation, I was thinking, what are the things that I see often in practice? And a few things kind of stick out in my mind. One thing is sending home a dog or cat with a corneal ulcer that doesn't have an e-collar on. I know owners are very resistant to e-collars. The cones that we usually recommend are ones that, extend beyond the head so that they can protect the eyes. But owners are very resistant. They'll not even make up, but to say every excuse in the world. But oftentimes that will be a reason why a corneal ulcer is not healing. Like, you need to let the cornea do its job to heal. And if it's getting rubbed at constantly, it's going to have a hard time doing that. So, just expressing the importance of cones, or at least close monitoring, so that they're not able to rub at those corneas. And then, which treatment to initiate. There are multiple different antibiotic drops and ointments and, blood serums and things like that. And I feel like sometimes people feel like they need to throw the whole kitchen sink at certain ulcers, and for certain ones you do, but most of them you can be a little bit more targeted in your approach, and it based on age, based on the depth of the ulcer, based on breed, certain things that can kind of help guide you in your treatment.
I think on the theme of excitement, I'm just going to call this out that I'm particularly stoked to have you here because if there was a residency I was going to go into, I think ophthalmology was the one that piqued my interest the most because their eyes, besides maybe pupil shape, are pretty similar and get similar disease processes across many different species. And so I think you get a real opportunity to see a huge spectrum of both animals, but also environments in which animals are kept to sort of work your magic.
Yeah, that's what drew me to the specialty in the first place. During my residency at Tufts, they had the large animal hospital right there. They had the wildlife center. They had a very busy exotics department. So in a single day, you're seeing dogs, cats, horses, an alpaca, and then an owl across the street all in the same day. And so that just kind of, kept things interesting because there's consistencies between the species, but a lot of differences too. So
I think one of the things that's, maybe worth talking about is not only the differences in treating different species and the different issues they get, but also just the sort of safety of the ophthalmologist and trying to do some of these examinations, treatments, diagnoses. It's just very close to the face of most of our patients. So can you talk a little bit about some of the ways in which you try to distance yourself while also, making a diagnosis, doing the treatment, and then maybe something that, general practitioners can glean from that? Because I would imagine some of the cases that you get referred to are just patients that are hard to handle in the general practice environment.
Yeah, for sure. And, when it comes to small animals, it's pretty rare that we actually need to use a muzzle, which is people find surprising because we are so close. For certain dogs and cats, there's just no way to get near them without sedation. But that's pretty rare. And then the ones that are a little wigglier, we have to sometimes use a muzzle. But for the most part, it's that fear-free training that we're all kind of used to now at this point. A lot of treats, even catnip on the table for cats, giving breaks in between, doing the different tests that we're doing, alternating between, one test to the other to just make sure that we're giving them plenty of breaks and not stressing them out. And then having, of course, really good holders and restrainers where they're not forcing the animal down, but knowing exactly how to elevate the head and open the eyes so that we can see things appropriately. But it's all that kind of pre-training that we're doing for the team, and then for the clients to give them the treats beforehand in the exam room as they're coming into the room. More treats, just kind of making it as pleasant of experience. And we've gotten a lot of feedback from clients saying, oh, they've always been so afraid to go to the vet until they come to us, and now they're running through the door. So I'm not the one really taking charge of that. My team and my techs are amazing at that, and I wouldn't be able to do as much as I can without them, for sure.
Yeah. Awesome. On the same line of the sort of differences in restraint and handling techniques, can you talk a little bit about what makes your practice special and sort of where the idea came from to have a standalone ophthalmology practice?
For sure. Yeah. Most specialties throughout the years that specialties have been a thing in vet med have been, with referral centers at ERs, that seem to be like the one way that you could be a specialist is with other specialists. And there's a use for that forever. I don't think we'll ever be replacing, big specialty clinics who have the multiple specialties and the 24-hour care. Those are super important. But, the demand is so high that there is room for, standalone specialty. Ophthalmology works specifically well for that just because, we can kind of limit the amount of exposure that we need for other specialists for the most part. We can do our exams in and out with, pretty high, fast pace. And so we just need a couple of exam rooms and a waiting room, and that's all we really need sometimes for our busy appointment days. And then we have our operating rooms, which are pretty self-contained with the equipment that we need. And then if we can kind of just self-sustain that, it made it pretty, quote unquote, easy to set that up in that regard. I know there are other specialties now too that are going more standalone, and I feel like you're going to see more and more of that as time goes on just because the demand is there. But when I was working in busy specialty practice, which is where I did my residency up at Tufts, and then afterwards, you find that I was in my own little bubble in the specialty clinic anyway, and so I'm like, well, why can't I be in my own little bubble completely away? And I miss having some of the specialists there to chat about cases, and but it is nice kind of having that experience for the client too, because they don't need to kind of go into a busy ER specialty referral center for most eye things. They can come in. It can be a more calmer experience. They're not dealing with life and death issues usually, and make it very targeted for that experience, and from the front desk to the back and techs and doctors.
Yeah, and we were talking before, the design of the spaces even, it feels a bit more catered towards, the services that you're providing. We were just saying before, the location in Long Island City is gorgeous, and I know a lot of our intention is put into that design for sure.
Yep, definitely. It's from the very beginning, we kind of made it designed for ophthalmology only. So, sorry. Making sure that the client feels that they're welcome right from the start, and it's a kind of calming experience for them, because most vet experiences can be stressful for pets and pet owners no matter what, and no matter how much you try, but to make it an experience geared towards it from the moment that they call, and the front desk team knows, okay, this is this eye issue, that eye issue. Most front desk teams at specialty services need to be familiar with a little bit of everything,
yeah.
and that's a lot, and they're not going to be specialized in each specialty that they're handling. And so just having the team being able to answer those questions from the get-go really makes a big difference.
It's incredible how intentional design really changes a client's journey through a clinic. Bond does a lot of that. I know a lot more clinics have been popping up with exactly that same concept of, making that vet visit comfortable, not only for the owners but the pets through that design. So it's nice to see that being continued.
Yeah, and it's fun. It's fun to kind of like use what we realize worked well, what doesn't work well in previous practices, and coming together.
It's become sort of this through line, I think, even in this podcast, that we like to end up talking about the design of veterinary clinics. It just, as Jesse said, it's become one of the things we're most proud of with our clinics in general, is that we are trying to figure out what does the client journey, patient journey look like, and then build a practice around that, rather than try to force the journey into what was the existing model.
Exactly. Yep. And there are other ophthalmology only practices throughout the country, and there's more that are opening, and it's fun to collaborate with them on what are you guys doing for this design, what are you doing in this regards, and everyone has different ideas, and it's just been fun to ask them what they're doing and get other ideas as well.
So to sort of switch topics, but on the same sort of lane as design, let's talk about a little bit of the design of the eye. I think in general the first layer is the cornea, and I think that is in many ways probably makes up the vast majority of the ocular disease that we see in general practice, but it probably makes up a bit of a smaller percentage of the things that are getting referred to you, maybe. I'll leave that up to you.
Yeah. No, I mean, we definitely see eyelid, cornea, and cataracts, which are all technically part of the anterior segment, if you will, the front part of the eye. That's going to be the most noticeable, that a client's going to see a cloudiness, they're going to see a squinting, redness, discharge around the eye. That could all indicate usually more surface disease. So we definitely see a lot of corneal ulcers that may have been treated previously at the primary care vet, not getting better or worsening or need surgery, and so then they'll come to us. So it still does make up a pretty big amount of the cases that we're seeing, for sure.
Great. And so, especially, some of the breeds and that we see, most common that most commonly have corneal ulceration or corneal disease of any type. We typically think of brachycephalic dogs or even cats because of the sort of shape and the exposure of the cornea. And again, I'll turn that to you to tell me if I'm right on those facts. But and then the mainstay of treatment, at least for most general practitioners, is choosing some antibiotic off the shelf. And so I wonder if there is more you can sort of bestow upon us about what we should be doing when these patients are coming in, other ways that we could be treating. You mentioned the e-collar, and I think probably for most traumatic injuries, it's probably the best, is that we're not causing even more trauma. Antibiotics, and then other options down the line.
For sure. I mean, I joke with my team sometimes that I say I could build a whole practice just on French bulldogs with corneal ulcers in New York City. Like, they're just so popular, of course, and they're very, very typical for getting corneal ulcers. So we see them a lot. I mean, I've counted some days 5, 6, 7 dogs in just one day out of like 25 appointments. So it's a pretty big percentage of the cases that we're seeing. So definitely things that I've learned that a lot of primary care vets are doing appropriately, is providing the e-collar, providing an antibiotic, pain medication, and then rechecking and seeing if it's healing. If it's not healing, ideally not just switching the antibiotic. That's like a big kind of pet peeve of mine, is that if a corneal ulcer is not visibly infected, and you'd be able to tell if it's infected, it kind of has that melting kind of white creamy appearance on the cornea, which is usually pretty obvious, but not always. Sometimes it can be tough. But if you're seeing that it's not infected and it still looks superficial and it's still there, just changing the antibiotic is probably not going to do much, to be honest. Like, it's not infected right now. Your antibiotic's doing a good job of keeping it not infected. So something else must be going on. Is there an abnormal eyelash that's rubbing? Is the dog rubbing on the cornea itself? Or is it more of like an indolent ulcer, a non-healing ulcer, which is the kind of typical ulcer that we see in these middle-aged or older French bulldogs? They're also called the boxer ulcers because boxers have always been the poster children for these types of ulcers. But as Frenchies have become more common, I kind of want to change the name now to Frenchie ulcers because we don't see that many boxers in New York City, and Frenchies, for whatever reason, are also getting this issue. And it's thought to be, an issue with the way that the epithelium kind of latches on to the stroma underneath it, that basement membrane, and it just can't really latch on because there's this membrane that forms. And so the best way to get it to heal is to remove that membrane with gentle debridement, and then the epithelium is able to grab on. So, if the cornea is trying to heal and it is just keeps slipping basically, and there's more and more blood vessels growing on the cornea, it's really just never going to heal until you remove that membrane with debridement. And so in general practice, numbing the eye and doing a gentle debridement with a cotton-tipped applicator is definitely appropriate. Works about maybe 50% of the time. And so for people who don't want to go to a referral, you want to try something at least to make them feel better, because sometimes that loose epithelium on the top just is painful. You can definitely do that in practice. Continue with the pain meds, continue with the antibiotic, and then if it's still not getting better, then it should have a more aggressive quote-unquote debridement, which is still pretty gentle. We do the diamond burr debridement, it's called, and so it's this little device that kind of it spins on the top, and it gently removes that whole top layer of the loose epithelium, removes that membrane, and then creates a nice surface for the cornea to finally heal. We generally place a contact lens on the cornea as well that has been shown to help speed up healing. Continue with the antibiotic. I usually don't change whatever antibiotic the dog is already on. Mm-hmm. If they're on Neopolybac, great. If they're on ofloxacin, great. I'm just going to keep it on that if it's not infected. And then keep on the cone, keep on with pain medication. I tend to prefer gabapentin for eye pain. And then about 85% of those are healed within 2 weeks. So oftentimes by the time they get to us, they've been treated for a few weeks or if not a few months. And so to tell them that we're finally going to get this to heal in 2 weeks is very kind of refreshing for them. So I always recommend that if you do have that kind of breed and age predisposition, brachycephalic, definitely Frenchie, middle age or older, not healing, and you've tried now, given it a week or two, and the ulcer's not healed, then something else is going on. So it should require a debridement, either you trying it out with the cotton-tipped applicator or referral for the diamond burr, or if you feel brave enough, doing the grid keratotomy, which is with a tiny needle towards the cornea. That is a little risky because these Frenchies are moving around and you accidentally poke the eye, you could perforate. So I feel like the diamond burr is actually much safer to use for those types of ulcers.
And so if you have the breed, but you do a fluorescein stain and it doesn't necessarily stain, classically as an indolent ulcer, which at least in my experience has been sort of this central stain uptake and then kind of like a halo around the edges. Yeah. Is it still appropriate to consider doing like a gentle debridement with a cotton-tipped applicator?
Definitely, yeah, because sometimes it can be hard to tell, like, is this an indolent ulcer or not? And so, yeah, proparacaine, numbing the eye, and just gently kind of touching the edges and seeing. And if you're able to just peel away that epithelium, then that gives you your diagnosis. That is an indolent ulcer. A normal, quote-unquote, cornea, even if it's an ulcer, should not be able to peel away that epithelium like that. That just shows you that there is that basement membrane kind of structural abnormality that happens. So,
and I'm likely jumping the gun here on some of the clinic questions that we receive from some of the clinic folks, but I think the hardest decision is typically what antibiotic should we reach for initially, and I think there's a good number of choices out there, and I think people get comfortable with one and they end up going with that for most of their life. But even in our clinics, we probably have a mixture of 5 different choices, and sometimes that's the same active ingredient but different delivery device, ointment versus suspension. So maybe you can give us some pearls there.
Definitely, yeah. Well, first, just on kind of vehicles, which is a good question. I would never use an ointment for something that's deeper than a superficial ulcer. So if it's a superficial ulcer, ointments are totally fine. Once you get into the stroma or, God forbid, a perforation, an ointment that enters into the eye, if it is perforated, could create a lot of inflammation because that kind of petroleum, petrolatum, can definitely trigger a pretty bad uveitis reaction. So if you're worried that it's maybe perforated or it's a deep ulcer that might perforate and the owners are just going to keep doing the ointment, just switch to drops at that point. So ointments, for me, it's only when they're truly superficial. And you should be able to tell it's superficial, with the stain and seeing that there really is no depth into it. Once you get into that stroma, even if you're not worried about it perforating, but it's best to just switch to drops at that point. And then I generally kind of break up the corneal ulcers from uncomplicated to complicated. And so uncomplicated are those superficial abrasions. They're picking up stain. Triple antibiotic ointment is totally fine for that. It's a good broad spectrum. It should heal, hopefully, if there's no underlying reason, within a few days. If they're not rubbing at it and you're applying the ointment, then it should hopefully heal pretty fast. Even if you're not applying the ointment, the cornea will probably heal on its own as well. The ointment's just there to help decrease the risk of infection. And then when I switch to, say, or reach for a drop, that's usually when they're more like the kind of complicated ulcers. And so, if you have one that is into the stroma, deeper, definitely if it's infected, that's where kind of shift gears, go towards a even broader base antibiotic, like a fluoroquinolone, like ofloxacin or ciprofloxacin. And some of those super infected ulcers, we're even adding in compounded cefazolin as well to get like the broadest spectrum that we can, just because you can culture the eye, but by the time you get those results, the eye might have been perforated by there, so you have to kind of throw the kitchen sink at them. So I'd say for superficial ulcers, uncomplicated, triple antibiotic ointment. If the owners have a hard time with ointment, you can definitely do a drop as well, like Neopolygram is a triple antibiotic of choice, and then kind of saving the fluoroquinolones for those more complicated, potentially infected, deeper ulcers, just because, at least in the Northeast, we haven't really had crazy resistance to ofloxacin, but I feel like a lot of people are reaching for ofloxacin maybe a little too soon, and eventually that is going to breed resistance, just like with any other antibiotic use, and then we might not have it. So most infected ulcers that we see in the city tend to respond well to a fluoroquinolone. For now, in other parts of the country, that's not the case. I feel like there is more resistance growing in like the Southeast, and some of my colleagues who have worked down there and just see that it does require a little bit more aggressive treatment, whereas in the city, we're kind of lucky right now. Maybe it's the humidity, maybe it's not, where they are still pretty responsive. So saving those kind of broader spectrum, bigger gun, quote unquote, antibiotic drops for when they are deeper, infected, perforated, then for sure, that's where we would want to do like a fluoroquinolone.
Okay, great. And if you were consulting on a, medical board for general practices across whatever the region that you work in, let's call it the Northeast, would you, recommend that, a network of general practices consider not even carrying a fluoroquinolone in the clinic to try to avoid some of those premature decisions?
It's tough. I mean, that's a good question, but I feel like if for cases that are not able to refer and they need to be aggressively treated, like it is good to have those antibiotics on hand. So I think just using it judiciously, and smartly, in a smart way. Like we do use ofloxacin a lot in our practice, but trying to use it only when it's deemed appropriate too.
Great.
And I will mention too, just about terramycin too, because that's a really good one that's been shown to be the most beneficial for kind of aiding in those indolent ulcer healings. It's the oxytetracycline, and that molecularly, I won't go into the specifics, has been shown to help speed up healing of those ulcers the best. So if I have a new indolent ulcer, quote unquote, that I'm seeing, and I'm doing the debridement and need to pick an antibiotic, I'll usually go to terramycin actually for those kinds of ulcers, because the study did show that it is beneficial. Is it absolutely required to use it? No, but that's kind of when I reach for the terramycin.
Yeah, with terramycin, I think we've heard somewhat recently, or I've even experienced, there's some irritation that can sometimes be associated with that drug. It's also become somewhat widely available on some big box stores on the internet. So, our clinics in particular, we've started to phase out carrying it just because it's so easy to get if we need it. And then we've seen some, at least when I did my internship, it was kind of overprescribed for kittens with URIs. We would just put everything on terramycin, and then we were seeing quite a bit of irritation with those particular patients.
For sure. Yeah, I don't think it's absolutely required to have, but that's kind of why, if you see in my records, why I'm reaching for that one for indolent ulcers. And then with cats, it's a little bit controversial too, because it is oxytetracycline with polymyxin, and there is thought that cats might have a strange reaction or potentially anaphylactic reaction to either neomycin or polymyxin. They're not really sure, because there's been previous reactions where cats who've administered like Neopolybac can just suddenly have a terrible anaphylactic shock and pass. So I've never seen it personally. I never really reached for any Neopoly of any types for cats, just because. And then polymyxin is in terramycin technically. So use it with caution in cats for sure, but with dogs, yes, it could sometimes cause a little irritation, but generally pretty well tolerated.
Okay. And then as far as first line treatment for superficial ulcers in cats, what are you reaching for typically?
So that's tough too, because the neopolys I would just stay away from. So in cats, I reach more towards like erythromycin. That seems to be a good broad coverage without that risk of the polymyxin or neomycin.
Awesome. Those are great takeaways for us.
Yeah, for sure. Before we head into our final segment of clinic questions, I know Jeremy, you did some research to see some recent literature that's been on some like top of your mind. And I know you wanted to throw some curveballs at Alex to see his take on it, but I would love you to share some of those.
Yeah, I'm working on getting my own segment on this show, which is like
the oddities segment.
Novel approaches per se. Sure. And so, I did a quick look search on corneal ulceration, what's sort of been out there since 2023. There are some kind of cool approaches. I think, one of the ones that has been out there and has a real use case is autologous serum, and I think that's going to come up in the clinic question, so we'll hold off on that. But, within the same vein, there's been a couple of other things. So I don't know what you've heard about when it comes to tilapia skin for corneal ulceration.
Yeah, so I've never personally used it, but I've heard of it, and not just for the cornea, but apparently for other wounds, like in skin use. Fish skin has been shown to be beneficial. I'm not really sure the exact mechanism why, but if you have tilapia skin on hand and want to try, but no, I don't recommend that at this point. But there's certain kind of compounds that are out there that can help stimulate healing. There's amnion drops as well that they're harvested from farm animal amnion, and that's been shown to help kind of be pro-inflammatory, create more of that scaffolding for the cornea to heal. So I feel like there are a lot of these kind of like bio properties, biological treatments that are potentially going to be out there and get commercialized for that kind of like scaffolding structure. I think that's really where it's going to be the most beneficial. I don't think it'll replace an antibiotic. Like that will always be needed to help prevent infection or treat infection, but there are definitely kind of compounds out there that might help stimulate more healing for sure.
Yeah, it makes sense. I think some of the research was showing that there's like an acellular protein matrix that can be sort of built in, and totally makes sense. I think these are typically scaffold related issues, right? I mean, that's why we're doing the debridement on those indolent ulcers. It's that scaffold just can't set up with that slippery surface underneath.
Yep, exactly. And for deeper ulcers too, that or perforations that they can't do surgery, and we're just trying to bridge that gap. If we can at least provide some kind of structure, then it might heal.
Right. On the same vein of some bio treatments, platelet-rich plasma and stem cells, is that anything that you've explored?
Yeah. So personally, I haven't either, but I know there's a few studies that, and one in particular I'm thinking of that looked at it for indolent ulcer treatment. So after you do the debridement, dogs that were being treated with that or not, and so the same kind of treatment before, but just adding on that or a placebo, and it showed actually not to be beneficial for those kinds of ulcers, for indolent ulcers. So I know we're probably going to touch on serum too, but platelet-rich plasma in general, and then serum has not been shown to be beneficial for indolent ulcers, for those non-healing ulcers, because in most of these ulcers tend to be vascularized already. So you have that blood flow to the cornea, sometimes, not always. And so if they're still not healing even with that blood supply there, then adding on more blood products is not going to help for those. I tend to reserve, any kind of plasma or serum, if we're going to get to that, for those infected ulcers, those melting ulcers that might help kind of stop that melting process for sure, and or provide that scaffolding for those deep ulcers. So definitely something for beneficial for that kind of regeneration, but for true like indolent ulcers hasn't really been shown to be beneficial. So,
okay.
Yeah.
Great.
Awesome. Well, now that we're here, in our new segment called Clinic Conversations, we collect questions from our team members to ask our esteemed guests what's on top of their mind. Some of them are related to the topic, some not. We only have a couple minutes, so I do have a couple questions that I know were kind of top of mind that are unrelated, but came up in one of our conversations with our MAID doctors, our new graduate doctors that are in our clinics right now, that were previously told to check the tear test, pressure, and stain in all eye cases. But the question came up, when would you choose to not use these diagnostics, or in which ones would you kind of omit while setting up a case?
For sure. Yeah, I mean, if you're worried that the eye is not stable in the sense like structurally stable, is it leaking, is it deflated, then for sure, sticking in a Schirmer tear test at that point is not going to be beneficial. Trying to get a pressure when the pressure is not there, not going to be beneficial. So it's like if it's obviously abnormal and you feel like you might do more harm than good by actually trying these tests, then avoid it. I think it's just not worth it. I think the best kind of tools for an eye exam is a dark room and a good light source. That's really going to be the most beneficial. And then utilizing those tests for most cases, for sure, if the eye seems structurally available, then they'll be beneficial because they can be really helpful in helping your diagnosis.
Awesome. Another question from our teams that as a technician also I think about a lot is when you're choosing eye lubricants, are all eye lubricants created equal? Are there certain formulas that you feel are more effective?
Yeah, it's a good question because there's a ton on the market right now, and I guess it depends on who you ask. I find that for the most part, any kind of lubrication in general is going to be helpful. I find, though, the liquid forms of whichever ones, when given too much, sometimes people feel like with the liquid ones they have to give it, every hour. But of course, there are preservatives in these drops, as they should be, to prevent contamination. And sometimes I worry that might be too much. So if you're worried about trying to lubricate an eye, better than just using a solution is to use more of like a gel, whether that has hyaluronic acid or not. There's so many different ones out there, and I don't really have, to be honest, strong preference at this point. Maybe one will kind of float to the top eventually once we kind of see more with it. But any kind of like gel will coat the cornea and maybe not be as needed as frequently, just because it does last longer too. So that in between, drop and ointment, there are more gel bases coming out, and they seem to be really nice. We're not causing so much greasiness on the face, but not causing just like pure wetness either.
Awesome. Another one, with Merle being crossbred into so many dogs that do not naturally occur in that color, do you think you'll start to see an uprise in Merle-related blindness in dogs in accompanying with the deafness?
We might. I feel like with the Merle, though, they generally have to be, like the two carriers, parents that see it, that you see like the true complete blindness. So as though it gets kind of percolated through, we might see more effects of it, maybe not the full blindness, maybe like more just microphthalmia or iris abnormalities, things like that. And we do see that occasionally for sure, but it'll be interesting to see what happens with that for sure.
And last one, since we touched on it a little bit before in the ulcer treatment conversation, is when to use serum. I think it's something that kind of comes up
all this time.
It's definitely at the top of people's minds for sure.
Yeah, I mean there are two papers that I kind of utilize for this, and both by ophthalmologists. One was by Seth Eaton, one was by Michelle Edelman, both in JAVMA from like 2017, 2018. And both of those showed that, serum and plasma did not help with indolent ulcers. So, so many dogs on indolent ulcers or have indolent ulcers and come in on plasma or serum, and I just stop it because, if it's not going to be beneficial and they're on multiple eye medications already, like why add more if it's not going to be helpful? So I really reserve, and when we have plasma that we get from a blood bank and then put it into sterile bottles, so it's easier to kind of access. I reserve that for more of those melting ulcers or those deep ulcers that have high risk of becoming infected, because it does really help that kind of that melting process. And so if you can halt that, that's going to be super beneficial for sure. So superficial ulcers, indolent ulcers, just not really needed for it. And there's potential for contamination. It is a blood product, and if the owners aren't handling it well, and then that gets infected, now they're putting infected blood product onto the eye, you're going to make things worse. So just trying to utilize it only when it's absolutely necessary, for sure.
Amazing. Well, that wraps it up for us today.
That was really good. I really hope you'll come back so we can maybe hit one of the other major eye problems that we see. I think there's a lot more our teams could get from you. So I really appreciate you coming in.
For sure. Happy to be here. Thanks for having me.
Yeah, thank you so much, Dr. LoPinto. That wraps it up for this week's edition of Bond Air. Alex, where can folks find you and the team?
Yeah, so we're at Veterinary Eye Center. We have locations at Hell's Kitchen, Chelsea, and Long Island City. Our website's vecnyc.com.
Awesome. Well, we'll be hearing from you again soon. Like Jeremy said, I love having these local specialists on is really fun, as our teams really do learn a lot from you all, and we're lucky being in the city and having access to that, so it's nice to share it through this medium. So thank you again so much for being here. Thank you, Jeremy. Appreciate you co-chairing with me. And for those at home, thank you so much for listening.
Thanks, everyone.